screen. Can you look down as far as possible, please? How you feel there? Look down. How's that there? Fine. Lovely. Look up as far as possible. How you doing there? Fine. Good. That's it. You are there? Good. There. How's that? Fine. You okay there? Yeah. So when I see that, I'm figuring there's not much wrong with C5 there, is there? We'll kind of give it a shove and it's fine. We test it out. It's no problem. And there, is it? And scaling there, Brandon, that saves his right arm, so we're not too worried about that kind of stuff. We'll get you to look over your right shoulder. You can hold that for about 10 seconds if you want to. That's your DBI done. No worries, right? A little lower press, you okay there? Yeah. Perfect. Okay. Okay. And a little lower press. Okay, ball. Could we try Spurlings at that point? Yeah, no dizziness or anything like that, lightheaded or something? Perfect. Okay, so you go extension. Observation, how you go there? Give rid of the show. You alright? Don't down the arm? No. Perfect. So now what can we do? We can forget about his neck. Thoracic outlet yesterday was a differential for us as well, wasn't it? As is kind of shoulder stuff. So for a quick shoulder strain, Trev, could you bring your arms just straight up over your head like that into the sides? That's perfect, isn't it? Gently drop them back down. That's excellent. Bring them up like that. And I want you to just make that big fist like that. Normally I do with the delivery and bias and all that, and you take a piss out. Come here. How do you feel? Not too bad. Now, what's positive is, where it looks like dropping down, what it looks like when you get a positive is one side starts going, and you usually get a big red face. Yeah, I really concentrate, and that arm feels really heavy, and there's no oxygen getting into my arm. No, like that, and it'll reproduce. If you've had a heavy, dead type of feeling in your arm, it'll reproduce it. Happy days. What's that for usually? From your test? COS from usually. Right, so the artery really there. Okay, so that's not out of the way. Perfect. Then we can move down. And generally, to get an idea, you usually go to the good side first, get an idea of the tissue sensitivity. If you look in the radial there, if it passes around the lateral humerus there, you can usually feel it as a bump around there. You have a rich internal life. What are you doing? I don't know. Yeah. Okay. That's what we get you to stand up there just for convenience sake, and then I'll get you to just do this. Bend 2 elbows like that. Okay. Lovely. How's that feel there? Right. Lock right out like that. Where's it go? Perfect. Back in there again. Yeah. And then hands down like that. Bend your wrist down like that. Back up like that. Neutral, in, out. Everything okay there? Lovely, that's any ball. Okay, so from there we look at the passive elbow. It looks like first is the fat side. Passive elbow, how does that feel there? Right. Just check what the normal range is like. Right there. Perfect. Palpate the radial head. Combination, supination. How's that there? How's that there? We're going to look at a few resisted tests now. So we get you to hold that just there, please. How's that there? Okay. The more tennis elbow tests, we go to pronate like that and do wrist flexion, then we stretch it out. And how's that feel in your elbow? That's fine. We're getting stuck now because we're running out of test. He hasn't got tennis elbow yet. Hold your hand like that. Like push this down inside. And we could try a couple of the other finger extensions as well. We can't get any symptoms there. So if all those three are negative, it's probably not a tennis elbow, yeah? Now your resistance test for your radial tunnel syndrome works a bit like this. You're going to stretch that supinator muscle, goes across there and around that radial. You're going to stretch that by pronating your hand. And I'm going to get you to try and turn your hand up. There you go. Come on. Any pain there? No. Perfect. If that's causing more pain than the wrist extension one is, then you could be looking at supinator radial nerve type of contracted there. That make sense?
No, I said again. It's too quick.
No, sorry, I do that. I was looking at video myself last night to see what it was doing. It was very fast, isn't it? Sorry, I apologize. So you're going to stretch that muscle going from there to there. You're going to stretch it across where the radial nerve is coming down that way. So often where something crosses a nerve, so if you look at the median nerve, like the ligament, the struthers, or something like that, yeah, or the carpal tunnel, for the radial nerve, you can get an impact there but where it goes through, passes through the supinator muscle there, and through the arcata frontalis around there, where something passes crossways across the nerve, that can impede the flow and irritate it and cause irritation to circulation and increase sensitivity to the nerve. So what we're doing is we're stretching that muscle across the nerve as we pronate the hand, right? That's supinator muscle. There's a picture of it in your notes there somewhere. Julie, you can see your notes there. And from that position there, so we stretched it across it, and now we're going to ask him to contract that muscle to put even more load onto the nerve. So we actually do a supinate your hand like that, and I'm going to resist that supination. Hold it for a little bit because we have a time component onto it as well, and to see does that cause sensitivity to the nerve and relax there first. How you feel? Yeah. No problem.
So there's more
Does that make sense?
generated on Cosen's. It's more likely.
Yeah, well think about it like this. I suppose we're putting more load on the tendon when we do that. If you just hold your hand like that for me there, that's what we can do. Let me push back in. That's really loading up the extensor, but it's not loading up. Now it's a really subtle distinction, and you can get a lot of overlap, and you kind of end up treating a lot of, making a few little problems and trying to work out how you're going to treat them. So that way, from the neurotag down to what's happening locally in the tendon, down to the physiology of the nerve locally. So frequently it's like a non-specific low back pain, it's a non-specific lateral elbow pain. That's what you deal with most of the time. In reality, that's what I would find anyway. So, that makes sense?
Yeah.
There's a little differential? Okay. How scientifically valid it is, I don't know. It's good practice, as we are at the moment in 2015. You might be looking back at Paul's video a couple of years ago. What the fuck was he talking about? He didn't know. He was wrong. He was wrong. Look into the study. But that's some tests you can use to help you. Again, if your pain is reproduced by your radial nerve neurodynamic test, that would be another key as well, wouldn't it? If it's reproduced by that and change structural differentiation, that would point to nerve sheath mechanosensitivity. Which we've yet to cover. Did we cover that for this one? No.
I don't think so, no. I wasn't here yesterday, so I don't know what you're going.
No, I'm trying to think of the last PBL. No, it wasn't in this PBL, was it? No. Right, so we did it in the last PBL, at least that's something on that. I must have lost a lot of PBL, I guess.
So over the neurodynamic test, you just literally holding it like that?
No, I do that. You can't do that. You have to put them up on the table. You're doing an exam.
Okay.
When you're driving your car, you can drive around like this now.
Okay.
You pretend you can, right? Well, you do your drive test, right? They don't do that at all. So, no. I'd say I generally do is I'll have to open the table and I'll do it up on the table. You can do a quick test that way there. Get you to lean your head the other way to me. You can do a quick test that way. Get them to literally do a weightless tip position and press their shoulder. You know, and see, that's fine as a quick test, but until you're fully fledged and certified, I would avoid doing quick tests and do long tests wherever possible. Is that about right, Jerry? Yeah. Perfect. So there you go. So you've checked the accessory movements, the physiological movements of the radial. Oh yeah, the accessory movements of the radial head. Again, we get in here. You just hold it like so, and just look at the accessory. Physiological is when you palpate, when you're doing that passive supination, pronation, you palpate the radial head. You're doing it. That's the physiological rotation of the radial head. And this one, like this here. Can I borrow your elbow?
Yeah.
Can you grab it?
Yeah, absolutely.
It's not brakes on these. It's the same ones. So yeah, these are pretty sturdy, aren't they? No, they're not.
Oh no, they're not.
I just unscrew it. So we're basically doing, you're putting your thumb around the radial head there, and as you rotate, you know that should rotate a little bit. The radius should rotate in there as you rotate the arm, supinate, pronate the arm, and you're just looking for quality of feel. And remember, you're going to have all your biases looking at it. So try and be really, really honest. Is it different to the other side? Is it different to normal? Do you know what I mean? But, you know, in theory, you can get restrictions to that joint, and that's an accessory joint that can stop you fully extending your elbow, stop you fully flexing your elbow, stop you pronating and supinating. And if it's bunged up, it can cause irritation in the area in general and lead to sensitivity in the area in general. So the accessory movement is literally just rocking it back and forward with an AP that way. That makes sense. You're going to literally put your thumb on it and rock it back and forward that way. Very simple. Okay, now, where does that leave me? I can't really know. The Varus valgus stress test. God, I haven't done it in years. You get them in your book. Do a little video. Now, will we have a look at the upper limb neurodynamic test while we're at it? Yeah, let's get you up on the table.